interpret each. And if we had time, we'll go over a few abnormal ECGs just to solidify the approach we discussed earlier. So start with, what is ECG? Any volunteers to tell me what does it stand for? Okay, let's see. Who raised his hand can proceed. Okay, Abdul Karim says electrocardiogram, excellent. Muhammad Azir. So yes, electrocardiogram or electrocardiography. And if you go in North America, they call it EKG. It's all the same. So an ECG is, as you see, this is an example of an electrocardiogram, and it is composed, if you look, 1, 2, 3, AVR, AVL, AVF, V1 to V6. These are what those here called limb leads. On the right side, this is called chest or pericardial leads. And we talk about what are they and how it is identified. So its main function of the ECG is to detect any changes in the electrical potential produced in successive area of the myocardium during the cardiac cycle. So that's exactly what this ECG happens. And it was invented by William Einthoven, and that's what we call the Einthoven triangle in the ECG. And if you look at the right side here, this is how the first ECG was done, rather than just putting a sticker. And still the same concept applies for the last 1 century. And it's one of the few procedures that really lasted with the same concept. And it is really revolutionized, and still it's really a standard of care, especially when you diagnose arrhythmias or an acute coronary injury. So in each beat, you can see this is a full beat, and between them, an isoelectric line, okay? And if we go more, enlarge that, so we understand each deflection, what does it mean? So if you go to this isoelectric line, it's called the TP segment, and this is where you reference for everything within the PQRS T deflections. So the P waves start, and that's what atrial depolarization happens, okay? And then an isoelectric line happen, and then you're gonna have the QRS, and then you have the ST segment, and this is where we look at acute myocardial injury, and then we have the T wave, and then you have the TP segment, which is the isoelectric. And to define that, the PR occurs from the beginning of the P to the beginning of the QRS. Okay, and that's what we call the PR interval. And the QRS from the beginning of the from the beginning to the end of the QRS complex, called the QRS duration. And then you have the QT, and that's where the Q to the end of T is called the QT interval. And that's what the major 3 intervals that we're going to talk about later on. And each large box represent 200 millisecond or 0.2 second, and each small box represent a 40 millisecond. We're talking about a paper speed of 25 millimeter per second, and you can't tell that if you go back here. This is where the calibration happens, and it's about two large boxes, which represents, this is the voltage in each millimeter is considered 0.1 millimeter volt. So that's the first thing, one of the first things you do before you proceed analyzing the ECG. And you're going to see it in every 12 lead ECG that is performed. Okay, so how that voltages are formulated. And as you saw, there is different morphologies for each lead representation. And it just give you a view of each part of the heart. And what happened is that for the limb leads, there are 4 leads: right arm, left leg, right leg. Right leg, it doesn't contribute in the limb leads. It's just there for as a electrical ground, so it's not counted. What is counted is the right arm, left leg. Okay, and then the chest leads, and that those are leads are positions within the 4th and 5th intercostal space, and that's really go around the heart in this way. In regards to limb leads, the 6 limb leads that we talked about here, so we have 3 leads, and when you go back, you saw the 1, 2, 3, AVR, AVL, AVF, have a memory of this, and you go to here, AVR is actually on the right, in the right arm, okay? And it's called a unipolar limb lead because it's not a summation of 2 leads. So AVR on the right arm, and then AVF on the left leg, and AVL on the left leg, left arm, sorry. So those are called the unipolar limb leads. The bipolar limb leads, which is 1, 2, 3, well, it represents the summation between the leads. So if you take the summation of between right arm and left arm, that's lead 1. And from the right arm to the left leg, that's 2. And the left arm to the left leg is 3. You don't need to memorize it, but it give you the concept. And when you do the ECG by yourself, you understand when you have a misplacement of a lead, and it's going to show in your ECG. And that's why it's very important, because if you have a false information, then you will have inaccurate analysis of the ECG. But to remember it, to make it simple, okay, if you have based on the L's, so we have right arm, left arm, it's 1 L, that's 1. And if you say right arm, left leg, you have 2 L's, left and leg, that's 2. And if you go left arm, left leg, you have 3 L's. You have the left arm, left leg, so 3. That's the way it's a mnemonic you can remember to understand which lead is a summation of what. So based on that, you're going to have all these results of the ECG, and both the 1, 2, 3 AVR, those are the unipolar leads. These are the bipolar leads, and from V1 to V6 are the chest leads. So now we're going to go to the cardiac anatomy. So you understand what is the QRS. So this is the PQRST complex. and subhanallah, في ماطور واحد, and it's in the SVC right atrium junction. It's called the SA node, and that's what fires. Okay, it takes over everything. And then في أسلاك توصل to another node. It's called the AV node. Its function, it conducts everything that is sent from the SA node down to the ventricle, but in a reasonable rate. Otherwise, if, for example, it really goes really high, then there's no safety net to protect the ventricles, because the ventricles, the atrial can tolerate high rates, but if the ventricle, then you're going to have arrhythmias that really life-threatening. Hence the development, Allah خلق al AV node as a safety net. The second function, in case the SA node doesn't work, the AV node will take over at a lower rate. For example, SA node start not to fire at a low rate, then the AV node will try to fire. The same goes with the bundle of his, and then the bundle is a big cable, comes out of the AV node, and then divides to the right bundle branch and divides to the left bundle branch. The left bundle branch divides into two divisions, the posterior division and the anterior division, or the anterior fascicle and the posterior fascicle. Okay, why important to mention that division? Because you're going to see it when we do access. We can see if there's a blockage here, it's called the left posterior fascicular block, and if there's a blockage here, it's called left anterior fascicular block. The same goes for the right bundle. If there's a block called right bundle branch block. Okay, and the SA node, it fires, and then it tries to depolarize the atria, and that's where you see the P wave. Okay, and then you have a delay where it happened in the AV node, and that where it explains if you have AV blocks, it happened at that level. And then you have the depolarization of the ventricle within the QRS complex. Okay, so after we went an overview about what is the ECG, how we do it, and then what is the anatomy, now I want you to go step by step about reading the ECG interpretation. Okay, and I want you to remember 10 steps. Okay, one, to make sure the ECG belongs to the patient. Make sure the patient name and it was entered in the right person. Two, to look at the calibration, and that's what I showed you in the side. This one, to look at that to see the calibration is accurate, and usually it has to be a 1 millivolt, which is around 10 small boxes. 3, to check the rhythm. Is it sinus rhythm or not? And then to look at the heart rate. Okay. After that, you look at the intervals that we talked about, the PR, the QRS, the QT. And then you look at the mean QRS axis. Then you look at the P wave abnormalities. You look at the QRS abnormalities. You look at the ST segment and T wave abnormalities. And if patient have a previous ECG, then you try to compare it to see if there's any evolution or change compared to the prior ECG. So those are the 10 crucial steps that I really want you to make the habit. It's going to take, like anything else, if you go to the gym, if you go to the, when you drive a car, when you have a habit, with time, you're going to do it without thinking. And that's what I need you whenever you read an ECG. After this lecture, develop that habit to go over these 10 steps. No shortcuts. So number 1, make sure the patient name here for confidentiality, the mean is not mentioned, but you're going to see it usually over here. If the nurse or the technician or the physician put in the name of the patient, it's going to be over here with the file number and other data. And then you have the computer reading. Most ECG machines now, they have algorithms and it's going to read most of the stuff for you that we're going to go over it. And that's helpful. For example, for calculations, probably they are more accurate than us human to do it. But make sure, the problem with the computer, it analyzes whatever you give it to them. And the algorithms are getting better and better. And also there's machines are using artificial intelligence. But so far, you want to make sure that the data is right before you really embark on what the computer says. And that's a frequent problem. And unfortunately, we're practicing now. We get called from the emergency about cases because they're read because there's acute myocardial infarction on the computer analysis, which is a lot of time. It's not accurate, to be honest, because of artifacts or misinterpretation of the ECG. That's why someone has to read it and reconfirm that. 2, calibration. So in calibration, as I told you, look at the beginning, look at the boxes of this, and usually in the calibration, you want to check there is 1 millivolt vertical box, which about 10 small boxes, because each small box and the vertical part is considered 0.1 millivolt. So if you go from here to here, it's about 10 small boxes, and that's a correct calibration. Okay, so 1 millivolt inscription of the calibration. Okay, good. After you check this, because sometimes, why it is important, sometimes it's changed for reasons. Example, patient have severe left ventricular hypertrophy. The QRS is so big that you cannot tell where is it. So sometimes you really have to change the calibration to adjust for that high voltage. It's uncommon, but it's done, but it's a good habit to check this before making any comment. Third thing to do is rhythm. Okay, and rhythm, what you do, you want to make sure there are 3 things that have been met. Okay, to say this is a sinus rhythm. 1, each P wave is followed by a QRS complex, and each QRS is preceded by a P wave. And a P wave is upright on lead 1, lead 2, and lead 3. Okay, and the PR interval is more than 120 milliseconds. If that's not the case, then that's not a sinus rhythm. Okay, so we make sure each P wave followed by a QRS, P wave, QRS, P wave, QRS. Okay, good. Then each QRS is preceded by a P wave. Okay, usually going to have a long strip, which is the one you really assess the rhythm rather than assessing each lead. And then you make sure that the P wave is upright. Here it's upright. Here it's upright. And here it's upright. Then good. Okay. And the PR is not short nor prolonged. And the definition, we're going to talk about it in the intervals. Then that's the case where you can call it sinus rhythm. Okay. After you identify this is sinus rhythm, and that's the case here, then you check the rate. And the rate measurement, there's different ways. And there's probably 3 methods to do that. I don't care about how it's done, but usually it's calculated by the computer, and it's pretty reliable. But if not the case, who can volunteer? What method you're gonna try to calculate the rate? Anyone brave to speak up?
I think it's done by calculating the boxes between the 2 QRS complexes or something like that.
Okay, good. So let's take this for an example. So here you have one large box, 2, 3, 4, and then probably two small ones. I see Maha. Excellent. Yes. I think the best way to do it, it's not fast, but it's the best way, more accurate, is that to calculate the number of small squares. Okay. And that's what you do. You try to calculate each small square. So each large one has 5. So we have 4 here, 20. And then you have 2, 22. And then you divide 1500 over 22. Then you have your heart rate. That's a method. Nawaf mentioned another method. Excellent. So you can calculate the QRSs in the whole strip, okay, and then multiply it by 10, which represents about 6 seconds. Okay, that's a method. The other method is the count-off method, where you try to each box, you calculate 300, 150, 7, so we go by each step. So that's one of the 3 methods that you can use. And remember, the normal rate about 60 to 100 beat per minute. If it's less than 60, it's bradycardia. More than 100 is tachycardia. So the best method really is accurate, and it never really fails you, is the 1500 over the number of small squares between each beat. Okay. A lot of people use the number of beats in 6 seconds and then times it by 10. That's what Nawaf mentioned. And or the count-off method, where you use each a large box, you go down by from 300, 150, 100, 75, 60, and then 50. Okay, excellent. So after you got the rhythm, we said it's sinus, and you make sure that it's a sinus rhythm or not. And if not, then you have to identify the arrhythmia type, and then you calculate the rate. And if it's a sinus rhythm and the rate is between 60 and 100, you call it normal sinus rhythm. If it's less than 60, you would say sinus bradycardia. If it is more than 100, you say sinus tachycardia. After you did that, then you're going to measure the intervals. And as we talked earlier, the intervals, you have 3 major ones. You calculate the PR, and that's from the beginning of the P to the beginning of the QRS, okay? And that normally, to measure, you have to know the normal and what is the abnormal, okay? So usually between 120 millisecond to 200, above 200 millisecond, it's usually an AV block. If there's each QRS, it's going to be first degree. If it's less than 120 milliseconds, and 120 milliseconds, as I told you, each small box is 40 milliseconds. So 3 small boxes gonna identify it as 120 milliseconds. If less than that is where you're gonna have a pre-excitation syndromes like WBW, Wolf, Parkinson, White, and that means there is an extra connection within the heart bypassing the AV node, okay? Or you have a junctional rhythm. So those are cases where it happens. So that's, you have to know what is difference, the normal PR, 120 milliseconds to 200 milliseconds, and that's with 3 to 5 small boxes. Beyond that, it's an AV block. Below that is pre-excitation or junctional rhythm, okay? And then you have the QRS, and go back to here. And then you have the QRS duration. It's either normal, there's no narrow, it's either normal or wide, okay? And wide when it happens, most of the time, if there is blocks below here, okay? And there are other etiologies for that. But usually, if it is more than 110 milliseconds, usually it is considered abnormal. If it's more than 120 milliseconds, and that's where we call it complete bundle branch block. And if it is between 120 milliseconds to 100 to 110, it's called incomplete. It doesn't matter to you to know that, but remember, if it is more than 120 millisecond, that is really abnormal, okay? After that, you look at the QT interval, and that's where you measure from the beginning of the QRS to the end of the T wave, and you take that number, but still you need to calculate the corrected QT. Okay, and what's a corrected QT? In that you adjust it based on the heart rate, and the number really depends on a lot of factors. If patient male or female, I don't want you to remember the numbers. It's not really crucial, but I want you to understand how to calculate the QT, and you have to correct it with the heart rate. So the correction for the QT, the corrected QT, CQT, is a QT over the root of the RR. And that's where you're gonna have the corrected QT interval, okay? Then you're gonna measure the axis. The axis, where you look at the ECG, before we go to the ECG, I just wanted to know what is normal axis. So this is a normal axis. If you look at the AVL, AVF, anything between -30 to 90, that's normal. But anything below that is called left axis deviation, from -30 to 90. And anything beyond AVF to from then +90 to 150 is considered right axis deviation. And anything beyond that up to 90 is called extreme right axis or no man land. But those are abnormal things you're gonna have. 3 quarters, the left axis, the right axis, and the extreme. And how you do that is very simple. The best way to do it is that look at lead 1 and lead 2. If the QRS vectors are all in the same way, that's normal. But if you see the QRS is down here and the QRS in the lead 2 is up, so it's called reaching each other, and that's where we called right axis deviation. If the QRS is up in the lead 1 and lead 2 is in negative QRS, so they're leaving each other, and that's what you call left axis deviation. Okay. So that's a simple way to understand what is the axis of the patient. Why it's important? Usually the computer going to calculate that for you, and there's a differential for that left axis deviation, right axis deviation. I don't want you to memorize it now. Later on, I just want you to have the method as I told you earlier. The pathologies will come later. So after we did name, calibration, rhythm, heart rate, intervals, axis, next we're going to look at the abnormalities, okay? So in the P wave abnormalities, we're going to look at the P wave and lead V and lead 2 and V1. You look at the lead 2 and V1. If you look here, usually it's small and biphasic. The first part, that's the right atrium depolarization, left atrium depolarization. And here is all in a positive deflection of the P wave altogether. Okay. And there's a criteria to define if there's left atrial enlargement or right atrial enlargement or biatrial enlargement. to do that. And I don't want you to remember now what is the criteria to be done, but I want you to understand that you need to assess the P wave for, at those two leads for atrial enlargement. After the P wave assessment, I want you to look at the QRS wave abnormality, okay? And this is where you look for left and right ventricular hypertrophy based on the QRS voltage, okay? And the width. You're gonna look for bundle branch block, and you're gonna look for any pathologic Q wave. Where are they? So here an example of the QRS, and you're gonna look at the width. You're gonna look if there's a pathologic Q wave. Q wave means that the Q wave is larger than it should be in the surface ECG electrocardiogram, okay? And you wanna look at the voltage and the width of the QRS, and based on that, you're gonna assess three things. You're gonna look at the pathologic Q wave, which means that if there is old myocardial infarction. Two, you're gonna look for ventricular hypertrophy, whether right or left. You wanna look at bundle branch block. And that's where you look at the V1, if the QRS deflection up with a wide QRS, most likely it's gonna be the right bundle branch block. And if it is in the negative deflection with a wide QRS, then likely it's a left bundle branch block. That's just a rough call for that. There is a criteria for this that we can talk about it in detail later on. Then you look at the Sdt changes. And this is that's my specialty, and as an interventionist, what we call ST elevation myocardial infarction. And that's why ECG, when the patient comes to the emergency, it has to be done within 10 minutes if patient develop with any chest symptoms. The reason for that, we have to identify ST elevation MI very fast so we can activate rapidly the cardiac cath lab team to come and do the procedure to open the vessel as fast as possible. And that's what we that's what's really important, very time sensitive, you should not delay. And this is one of the few things in medicine that really made a difference. And that's why ECG is very crucial until now. For the last 100 years, since its inception, it's still used currently. So when you inspect for ST elevation, you look at you try to compare it to the TP segment. If the ST elevation is really high, it should be, your reference is the TP segment. If it goes up, there's a differential for ST elevation, of course, but in general, if the ST elevation, you're gonna really comment on it, your reference is the TP segment, which is between the end of the T wave to the beginning of the P wave. Okay? And then you're gonna look at the T wave, okay? And that's where you're gonna look if the P wave is peaked, if the P wave is flipped, which is called T wave inversion, any changes that happen in the T wave, it can be, there's a long differential. It can be just strain from hypertrophy of the ventricle. It can be from metabolic, it can be from medication. There's a lot of differential. But what I want you to remember is that have a habit as your 9th step to really comment about the ST segment, whether it goes up or down, and look at the T wave morphology, whether it's peaked or inverted, or sometimes biphasic. All that, there's a differential for each pathology. Okay. And last but not least, number 10 is that I want you to, ask about prior ECG. And that's where you're gonna try to compare it to a previous ECG before you say, patient is, you say there's new changes, because sometimes there is a change that is already old. It's the same thing goes with anything else. Chest X-ray, lab result, always compare to a prior one if you have one. Okay, so that's what I really want you to grill it in your mind, the 10 steps in the ECG interpretation, from making sure the patient name, the calibration, the rhythm, the heart rate, looking at the intervals of the PR, QRS, and QT, looking at the QRS axis, looking at the P wave abnormalities, looking at the QRS wave abnormalities, where you're gonna look for ventricular hypertrophy, van der Waals block, or pathologic Q waves, looking at the ST segment and the T wave abnormalities, and then compare it of a prior ECG if you have one. Okay, so if you go this with every ECG, then you're really gonna have you're gonna learn, you expand your knowledge, you're gonna have the experience, and you're gonna be really fast. This is gonna be like in seconds for you, because you really develop the habit with time. It's like with anything else. Before we go to abnormal ECGs, and where we're gonna ask, I'm gonna ask any of the attendees to go over these 10 steps. I'm gonna bring it back and forth. Before we do that, any questions from the attendees before we move to ECG game?
Doctor.
Yes.
Yeah, about the axis, we just go with a thumbs rule. That's it. We don't need to calculate with the other method.
You can, but I want to simplify it for you, because
so it's not important.
It is important later on, but if the beginning of your at the beginning of your interpretation in your career, I want you to develop the habits. Then with time, you're gonna deep dive in each one. I'm really simplifying it as much as possible. ECG sessions, for example, for ER, physicians, for cardiology, we really, each one of them, we go really for days. For example, in cardiology fellows, we really go deep. For example, in axis, this is a whole session by itself. But you cannot, it's like, you cannot learn all medical school, for example, in 1 year. And that's why you take it over years. The same thing here. I just want you to do, what I think is important is that the methodology of interpretation and understanding what is normal, abnormal. The next step then later on, once you really have this habit, then you're gonna deep dive and try to go over the, for example, the axis. I can give you a session about it, how to really calculate it. It's very simple. It's time consuming, but it's simple. And the computer does it a good job most of the time. I hope I answered your questions.
Thank you.
Assalamu alaikum.
Alaikum assalam wa rahmatullah.
Doctor, I just have one question. And let's assume that we have a patient known to have myocardial infarction before, and I did a new ECG for him. Yeah, and how to differentiate between the old changes and the new one? Yani.
Well, you compare it, you bring them together, and you're gonna go over these 10 steps, right? You're gonna look at the rhythm, you're gonna look at the rate, you're gonna look at the intervals, you're gonna look at the axis, you know, P wave, and each, if you see any difference, changes, then you know what, you're gonna know, there's a new change happened. For example, if patient have baseline ST depression, about 2 millimeter, and the ST depression, it looks like horizontal ST depression. And then you do, patient come in with an ECG, and then you do the new come in with chest pain, and you do the ECG, and it showed the ST actually normalizes. Okay, and that's actually dynamic. This is a change, and maybe it's considered an ischemia. Some patients, especially in women, we know that they have baseline. Some of them have baseline ST depression, and then if it normalizes, I mean there's something wrong happened. It can be really considered an ischemia. So that's how you try to compare, because seeing a normal ST depression, ST segment without deviation by itself, sometimes it doesn't, if you didn't have a previous, if he has one. If he doesn't, then you assume what you see, it is his baseline. I hope I answered your question.
Yes, thank you, doctor. But if the patient came for the first time and he diagnosed with myocardial infarction with ST elevation, after the treatment, does the ECG will come back to normal, or it will be same? And after that, if he come again with chest pain, I compare it for the normalization or more elevation, just to make it clear for me.
A good question. Sahih. So sometimes patients have a heart attack before, myocardial infarction. For example, let's say the anterior leads. Okay, they have Q waves, ST elevation, then they go through the evolution, they change with the T wave, the ST. For example, some of them, they have persistent ST elevation. Let's say they have a large infarct or they have aneurysm, and then they have baseline ST elevation on discharge from a hospital, about 1 millimeter. And then he comes back with chest pain, and you do another ECG, and then you see it's actually, there is a ST elevation, but it's the same as before. Then you're not considered there's an acute, a new other acute event, because that's the same as the baseline on discharge, right? So that's really helped you.
Okay. Yes. Thank you, doctor.
My pleasure. Okay, there's a question about 16 lead ECG and when we need to order it. Very excellent question. So what he's talking about, Abdurrahman, is he's talking about posterior leads and right-sided leads, and that where we do extra leads on the back and also on the right side. And that's where we suspect that we're missing an acute myocardial injury, like a myocardial infarction, ST elevation MI, on the right side and the posterior leads. Because there is about 1 in 10, you're gonna have isolated posterior that you do not see in the surface. And that's where we put the V5, V7, V8, V9, those are posterior leads, and the right-sided leads for the RV infarction. Okay, and that's where you suspect that you need to rule out isolated posterior infarction, or you want to rule in right ventricular infarction. And that's the value of that extra leads to be done. This is the only reason they usually they do it in the emergency department. And that's a session you can organize it مع الزملاء في نبض inshallah, a whole session about acute coronary events or ECG emergency cases, where we go over all these details, and you're gonna enjoy it inshallah. There's a question by Sultan. Does U-wave has an importance in ECG interpretation? Yes, sometimes it's found in the ECG. Sometimes you can't see it. It can be part of a normal variant. Sometimes it's abnormal, or it's not a U-wave, it's something else, like Osborne waves. Would happen in hypothermia. And that's also, we're gonna talk about it when you analyze the part of the ST segment and T wave abnormalities. Whenever you do analyze the T wave, you're going to analyze the TP segment too with it. For Bender branch block, look at lead 1 or 2 or 1 and AVF. Okay, excellent question for us. Yeah, we're gonna talk about a session about conduction abnormalities, and that's where we're gonna really deep dive. I wanted to really, as I told you, I wanted to drill down on the methodology, and then pathologies we're gonna take one by one later on in a different session, inshallah. Any more questions before we move to the ECGs, abnormal ECGs? So while we're waiting for questions, I'm gonna bring you ECGs to interpret. Okay. Okay, very good. So now share it. Okay. Can you see it or not yet?
Not yet, doctor. Yeah, now we can see it.
You can see, excellent. Okay. Very good. So any volunteer, and I want what I need you to do is really, as I told you, I don't really care about finding the abnormality, but I want you, my goal of this, I just want you to go over the habit of the 10 steps. Okay. Who's volunteering? ما شاء الله محمد الساهل، تفضل محمد.
أهلا دكتور. بالنسبة في البداية I will confirm the patient identity.
أحسنت.
Then I will check the calibration.
Okay.
I
so
see
here.
it. Yeah.
So
Then,
what is the calibration here? It's about 2 large boxes, huh?
Yeah.
So
it's
that's
just-
right. That's a good calibration. It's a 1
Yeah.
millivolt. Excellent. Next.
Then I will check rhythm.
Okay.
I forgot how to.
Sure.
write.
No problem. So you look at the rhythm. Excellent. So in the
Yeah.
rhythm, you want to make sure it's sinus or not sinus. صح?
Yeah.
To make sure it's sinus,
P
you want
wave.
to أحسنت.
P wave before P wave before QRS.
So P wave before each QRS.
Yeah.
Is it there or not?
Yeah. It's
Yes,
there.
right? Okay, 1. Excellent. Next.
Then I check rate or
No,
That's
not for the rhythm. We didn't finish the rhythm yet.
Yeah. I'll check the RR interval. Or
No, that's for the rate. No, I want to
Ah.
stay at the rhythm. We said we have to make sure sinus. To make sure sinus, we say it is P wave followed by a QRS. That's right.
Yeah.
It's here the case. Good. Two, if every
P wave
QRS is
upright and
preceded
lead
by P wave,
P wave and lead
right?
one.
So every
P-
QRS preceded by P wave. Excellent.
Yeah. And then P wave is upright. And
Excellent.
lead
So it's a
one,
positive P wave axis on the
Yeah.
lead 2, 3.
1, 2, 3.
Yeah, exactly. Excellent.
Yeah.
So that's, and then,
PR interval 3 small boxes.
okay. So it is more than 3 small boxes, right? And
Yeah.
it is not more than 1 large box. 1, 2, 3. If it's not more than 1 large box, then it's good. So you have a
Yeah.
sinus.
Sinus rhythm. Sinus
Sinus.
rhythm.
Sahih.
Yeah. Then I
Next.
will check rate
Okay.
by RR interval. I will count the small boxes. Then 1,500 divided by small boxes.
Yes. So you
Between
can
the
calculate it, the small boxes, and divide 1,500 over the small boxes,
Yeah.
right? But so that's between here to here, right?
Yeah.
So it's a lot, but this one, the easier way, whenever it's a slow heart rate, so you can do that, that's fine. But what I would do here, just calculate the QRSs and times it by 10. So 1,
2, 3, 4, 5, 6, 7, 8, 9, 10, 10. I think 100.
no, so sorry, 10, you divide, you multiplied by 6. So you have 10
Six.
by 6, 60.
60. Yeah,
Excellent.
60. I think
Very
it's sinus يعني normal يعني within normal range.
Okay, very good. So normal
60.
sinus rhythm. Excellent.
Yeah.
Okay,
Then I will check the interval.
very good.
Yeah.
Before, okay, you can check the interval if you want to go with axis. Was good. So
Yeah.
interval of the P wave, you already the PR segment, you already
Yeah.
said
2 to 3 small boxes.
okay. So it should not be more than 1 large box and not
Yeah.
less than 3 small boxes, right?
Yeah.
So if it is between those, so you calculate 1, 2, 3, 4, 5.
Yeah.
So 5 by 40 milliseconds, 200 milliseconds. So let's say about here, it's not really clear, but if you go here, so 1, 2, 3, 4, 4.5. So
Yeah.
you pay about 180 milliseconds. Okay. So you didn't have an AV, first degree AV block, and you don't have pre-excitation. So good. Next.
Then I will check the QRS.
Excellent.
Yeah. But I'm
And the
not sure.
QRS, is it narrow or wide? That's it.
Yeah. I think-
Wide,
yeah.
anything beyond 110 millisecond. So it's about 3 small squares, right? So here, if you go closer, so look here. So you start from here, 1, about 1 and 1.5 or 2. So it's about 80 milliseconds.
So it's
So that's narrow, right?
yeah.
Excellent. Okay. Next.
Then I will check the QT. It should
Okay.
be less than half of the RR interval.
Okay, good.
So
Or you can see the calculation here. The calculate the corrected. It's about 406, which is normal. And they're very accurate in the computer. But you can, what you do, as you said, you look at the, if it's less than half the RR, then it's normal.
yes.
Okay.
Then I will
After-
check.
Yes, go
Then I
ahead.
will check the
Axis.
axis. Yeah, it's upright and the lead 1 and 2.
Okay, very good. So you have upright, so normal axis. Very good.
Yes. Then I will check P wave abnormalities.
Okay. And where do you look for it?
Lead 2 and V1.
Good.
Here, I think lead V1.
So you didn't need to know the abnormality, but it
Yeah.
doesn't look really wide or peaked. The same thing here. It doesn't look really the first part or the later part really enlarged, suggestive of atrial enlargement. So there isn't. We'll talk about chamber enlargement in a session. But next,
Yes. Then I will check QRS wave abnormalities.
okay. So
Uh,
do you feel there is it wide or the voltage is high?
I'm not
The
sure, but
voltage, it's not really large. There's a criteria. We'll talk about it. The voltages are really less than 2 large squares. Most of it here in the limb leads, and less than 1 large square in the limb leads. And hypertrophy of the ventricle, right or left, or Bender branch block. We'll talk about it in different sessions. But this is normal. QRS. Next.
then I will check ST segment.
Okay.
I can see in lead 2 and AVF, there is an elevation of the, and lead 3, maybe.
Excellent. Yes, correct. There is ST elevation. How you said it's ST elevation?
And I'm not sure, but by looking, it seems to be elevated. Yeah.
Okay, so that's why I just wanted to have a method. The method is you look at the TP segment. You see this?
Yeah.
Here, this is your reference. You compare this to this. If you look, let's look at this one easier. So this is your TP segment. From the end of the T to the beginning of the P, and then compare to this.
Yeah.
Big, dramatic elevation, right?
Yes.
The same goes here. Here's the TP segment, and this is the elevation, because here, where's the elevation? It's about subtle, not like here, but there is ST elevation, you're right. So there is ST elevation, there's a differential for that. Here, I didn't give you the history, and the way it looks here, it's really is called the tombstoning. It's suggestive of an acute myocardial injury or acute myocardial infarction. The thing that we did not talk, which we're going to talk about a session about localization of the infarction, is where each lead represents, right? So
Yeah.
to remember it, so 2, 3 AVF here is considered which wall?
Inferior.
Ahsant. Lead 1 and AVL is considered high lateral. Okay,
Highlight.
correct. V1 and V2 is considered anteroseptal. Okay, V3 to V4 is considered anterior or anteroapical. Okay, V5 and V6 is considered anterolateral or lateral. Okay, it depends. Really, it's not important. Just make sure this is the lateral anterior, anterior septal, inferior, and the high lateral. So that's how you localize, but that's we're going to talk about it in a session just for acute coronary events. So excellent. So we picked up the pathology. There is an acute myocardial injury with ST elevation, probably myocardial infarction. There's a differential for ST elevation, which I will talk in a different session, but it really involves the interseptal, apical, anterolateral, so an inferior. So this is an extensive anterior and inferior myocardial infarction. This is a very large infarction, which means that one of the vessels, which called the left anterior descending, is really very large. Probably it's the one occluded, and it wraps around the left ventricle and goes back, covering the inferior wall. And that's why you have both territories involved. Okay, then after you did that,
Then I will compare if there is any previous ECG.
Ahsant. Excellent. Very good. That's what I want you to get out from this session today, is the method, the systematic way. The abnormalities of each, we're going to go over it in a different subsequent sessions. I'm more than happy to do it. And we go deep dive, for example, in the rate, the rhythm, exactly. I'll show you the pathologies, because once you see them, you're going to have a pattern recognition of these things. But before we jump to the pattern recognition or identifying abnormalities, I really want you to develop the habit before identifying abnormalities. But you did very well. Excellent job. المفروض تيجي عندنا تقدم عندنا في الكاردياك سنتر.
Thank you, Doctor.
الله بالتوفيق إن شاء الله.
شكرا.
Thank you very much. I hope you'll that was helpful, and I wish you all the best إن شاء الله. بالتوفيق. إذا في أي تحتاجون أي تواصل سلايدات أنا بعطيها للمنظمين إن شاء الله. وأشكر الأخت شهد طياش، يعني ما شاء الله she organized it very well. And I'll give her my email and my contact. And if anyone interested in cardiology or wants to work with us or join us for observership or attachment, I'm more than happy to help. بالتوفيق ورمضانكم مبارك عليكم جميعا.
يعطيك العافية دكتور، شكرا.
الله يعافيك.